It's my pleasure. My name is Gerald Batist. I'm the head of oncology here. It's my pleasure to introduce Sally Frampton, who is a postdoctoral research assistant actually based in the faculty of English at the University of Oxford, and was previously at the Centre for the History of Medicine at University College London. And she's going to talk to us about statistics and abdominal surgery over ovariotomy. Sally.
Thank you. And I'd like to thank McGill and Thomas, who is possibly Canadian by now, for having me over. Perhaps one hopes. Okay, so the introduction of ovariotomy, which is the removal of a diseased ovary through the abdomen, was one of the most significant and controversial developments in 19th century surgery. The first procedure established into surgical practice that involved making a large incision into the abdominal cavity. Ovariotomy was seen to symbolise the rapidly growing power of surgery during this era. It was a hugely important testing ground for many questions surrounding the professional and moral framework of surgery, from the propriety of risk-taking to international competition in surgery to the necessity of medical specialism. Its dramatic impact was felt in medicine and beyond, as it went from being decried as an immoral, perhaps even murderous procedure in the early century, to being held as the crowning glory of surgical ingenuity, and then later in the century becoming once more the subject of criticism, as ovariotomists were accused of over-operating, as some surgeons began to remove women's ovaries for conditions such as menstrual pain, epilepsy, and even hysteria. And if you're familiar with the operation, it may well be this aspect of the operation's history that you're familiar with. In 1879, the American gynecological surgeon William Goodall wrote that with its lights and its shades, its friends and its foes, its converts and its perverts, the history of ovariotomy reads like a romance, which I think is possibly the best quote I've ever found about ovariotomy. But it more seriously, it captures something, I think, of the drama which I think surrounded the operation, and the fact that it did become this focal point of many medical, technical, ethical debates which were being put forward against abdominal surgery in the mid-century. And some ovariotomists suffered professional setbacks as a consequence of these debates. As you might imagine, from such a visible and much discussed operation, statistics played an important role throughout the debates about its justifiability and efficacy. In this paper, I want to focus on the operation during the mid-century, when the question of statistics, I think, became particularly important. At a time, I would argue, when the question of how the operation's results might be best conveyed was almost important as the questions surrounding the technicalities of the operation itself. These debates show, I think, how surgeons were cognizant of the limitations to statistics, which we've been discussing today, and that many believe that other methods of representing their cases were needed to complement statistical analysis. I'm afraid this is very much about the British experience of the operation, so but if anyone wants to talk a bit further about some of the international aspects, maybe we can discuss that afterwards. So, yeah, sorry, I assumed everyone here would be fine with scary images. So the early 1840s was a particularly important time for the operation. Cases of ovarian removal have been recorded since the first decade of the 19th century, specifically 1809, Ephraim McDowell, who was a surgeon in Kentucky. And it had been attempted a few times after that throughout the 1820s and 1830s, but the locus of interest kind of moves to Britain at this time, and then a bit later in the century, America starts to predominate again, so there's lots of international competition really around the operation. In the 1840s, confidence increases enough that the numbers attempting the operation rises considerably, although I stress this is still quite a very small subset of practitioners, but enough, I think, that there's a critical mass, I guess, has been reached, and the professions start paying attention to the operation. Partly also this is because London surgeons start performing it, and before that it mainly been done by provincial surgeons. During this time, the debate as to the justifiability of the operation was at its most polarised. For an increasingly vocal group of advocates, the operation was held up as a sign of advancement, heralding a new era of surgery. For opponents, it was nothing more than a useless and possibly criminal procedure performed by practitioners that were famously nicknamed belly rippers. Much of the objection tied up with the question of how necessary an ovariotomy was. Ovarian tumours, as you can see here, could be horrendously disfiguring, debilitating, were generally considered invariably fatal if not surgically treated. And you can see quite how huge the tumours could grow without surgical intervention. And this is from Thomas Spencer Wells' Disease of the Ovaries, and Ulrich mentioned Spencer Wells earlier. However, patients could live with the disease for some time, sometimes months, occasionally even for years. So leading critics called into question whether, ethically speaking, the operation such an operation like this could be justified. In the 1840s, interest moved towards formulating statistics from the cases published in a bid to bring some kind of closure to the ovariotomy debate. Statistics, as we've heard, figured more prominently in medical culture than ever before. Expansion of hospitals, the public health movement, all these were enabling the collection of vaster amounts of medical data. And this worked as well in tandem, I think, with the flourishing medical press in the mid-decades of the 19th century, which I think probably afforded greater opportunities and possibly put greater demands on surgeons to publish cases as well, and I'll come back again to that a bit later. But essentially in the mid-century, ovariotomists were being increasingly put under intense pressure to reveal the details of their cases. At this time, the Manchester obstetrician Charles Clay, one of the most prolific ovariotomists, began a long and unbroken series of cases. And it's during this time that the word ovariotomy is coined, and it's coined specifically to describe Charles Clay's work. You can see before the term had been coined, there was all sorts of ways of describing the operation, one of which was peritoneal section. This change in nomenclature, I think, was important. It was a transitional moment in the history of the procedure as the operation shifted from a range of diverse acts, often private endeavours, to a single identity. And as such, all occurrences were expected to be relayed through print and thus available for public consumption and comparison. It was Charles Clay's publication of his first 5 operations as the standalone pamphlet you can see there, Cases of Peritoneal Section, in 1842, which first drew the medical community's attention to the issue of ovariotomy statistics, and also their limitations and some of their problems as well. In the pamphlet, Clay collated a list of all known large incision ovarian operations. So already we're seeing complications occur because he didn't include ovarian operations where people made a small incision. So we already see the operation diverging and changing. As Clay calculated it, there have been so far 10 successful cases and 1 failed case of the operation. His statistics, however, were met with derision. In a rather vicious review, the British and Foreign Medical Review tore apart his methodology, the reviewer pouring scorn upon the way Clay had chosen to group his own fatalities. What was critical here was that Clay had chosen not to count 2 of his fatal cases, because he had operated upon them only to find that once he'd opened up the belly, the tumours were not ovarian, they emerged from the uterus, and he'd not proceeded to operate. And so he had seen fit not to add them in with all the statistics of his operations. Clay's approach outraged the review. And in fact, the writers took it upon themselves to rejig Clay's table of statistics into 2 tables that they felt provided a more accurate picture of his experiences. One table of completed operations, which I think was this one, and then there was another one as well of the ones that hadn't been completed. And I kind of wanted to put that in because I think it's important to acknowledge the active role the medical press played at this time in shaping a lot of these debates around statistics. And if we're thinking about different forms of surgical evidence as we are today and the availability of that evidence, I think we do have to consider the role of medical journals, the role they played in the past, but also in the present as well, and I'll touch on that at the end of the paper. Critics, like the critiques, like the reviews of Clay, only bolstered the firm view of opponents of the operation that some ovariotomists were not disclosing their failed cases. Failure to publish less than successful results has, I would suggest, been a perennial concern in medicine. I think it's still a concern today. And 19th century medical journals often picked up on this problem. I'm just going to go on an aside because I found this recently. It's a column that started in the British Medical Journal in 1879 called Our Confessional, which was a column where doctors were invited to anonymously disclose their failed cases, their mistakes, cases that hadn't ended well, which I think really gives you an indication of how big the problem was considered to be, that people were not reporting failed cases and mistakes and so forth. In the 1840s and early 1850s, a number of ovariotomists stood accused of failing to reveal their cases from their practice that had ended fatally, and statistics came to be a powerful tool for those sceptical about the operation. This was certainly so for the obstetrician Robert Lee, who was known for his distaste for major operations in obstetrics and gynecology. Lee was a vicious opponent of not just of ovariotomy but caesarean section as well, and he decried them both as part of a rage for cruel and bloody operations. And the Wellcome Library actually have his diary, which is fascinating because you get to see all his personal thoughts about these operations, and he really was absolutely dead set against these, and he thought it was a terrible thing happening in medicine. Lee collected statistics on both of these operations. And he made his statistics for ovariotomy public at a controversial meeting at the Royal Medical and Chirurgical Society at the end of 1850. And it was here he announced his data regarding 108 cases of ovariotomy that he had collected. And through these, he had calculated a mortality rate of 35% for all attempted ovariotomies. Two names were noticeably absent from his list, though. Daniel Waln and Frederick Bird, both London-based practitioners who had been performing the operation in private practice, and as most ovariotomies were. So it was interesting hearing Stephanie's discussion of how there was actually very few operations happening in the general hospitals at this time, and most ovariotomies were happening in private practice. Lee claimed that both men had failed to furnish him with the full facts of their experience and had not published all their unsuccessful cases. Bird, who was present at the meeting, expressed shock at this humiliating public announcement, and it's a great read, this meeting. You can feel the kind of tension in the room as people start to circle on Frederick Bird. He claimed that he'd already sent Lee his statistics for the operation thus far, 12 cases, of which 8 had been successes. But herein lay the slipperiness in defining what exactly the most desirable method of data collection was. Bird admitted that on numerous other occasions, not reported, he had opened up the abdomen to make an exploratory incision. Apparently wary of trying to diagnose blindly, so usually surgeons were just making an educated guess really about whether it was indeed an ovarian tumour, Bird had begun to open up the abdomen to ensure that ovarian disease was present before he then went ahead and did a later major operation. The report of the meeting gives a palpable sense of tension in the crowded room as Bird was asked how many times he had made an exploratory incision. Bird responded that, and I quote, "Probably he might startle some gentlemen by stating as many as 40 or 50, but this number he was speaking quite at random." Bird denied that any of these exploratory incisions had been fatal, but this was contested by Lee, who believed that at least one had been. Regardless, major damage had been done to Bird's reputation and to the cause of ovariotomy. Bird's public humiliation put a well-known face on the vague and nameless fear that dozens, perhaps even hundreds of abdominal procedures were being performed secretly, and thus, as of yet, the true scale of the operation's risk had not been adequately conveyed. Lee was evidently delighted with the stir his paper had caused, and his role in encouraging the profession to think deeply and critically about both ovariotomy and caesarean section. In all of which I was victorious, or rather the truth triumphed, he recorded in his diary after the meeting regarding his public battles. Lee's use of statistics was ostensibly to attain an objective representation of the operation. But what they had really done was provide Lee with an opportune way through which to rather dramatically reveal what was not represented. Indeed, perhaps even more important than the statistical calculations he made, that over a third of the patients were dying, was the way in which he had made withholding information on ovariotomy now seem completely unacceptable. Risky surgery could no longer be private, it had to be judged collectively and publicly. The truth could only exist if it existed publicly. Surgeons who were thought to resist this trend were vulnerable to accusations of misconduct. And this shift in surgical practice was felt profoundly by some of those people who were personally and unfortunately involved. I don't think it's a coincidence that Daniel Warren and Frederick both gave up ovariotomy very, very soon after this debate. And Frederick Bird's obituary talks a lot about the anxieties he felt about the operation, and that's why he gave up. And I think that those anxieties could be read as the anxieties of operating, but perhaps also the professional anxieties that came with doing it. Despite Lee's personal victories, the controversy surrounding Bird seemed only to clarify the unsatisfactory nature of surgical statistics. Surgeons pondered the degree to which statistics could tell the profession not only about the length to which a successful operation prolonged life, but also the extent that involved a decent quality of life afterwards, and this becomes a huge concern in ovariotomy and all throughout the century as well. The days, weeks, even months after ovariotomy had been performed could be a time of considerable anxiety. During these mid-decades, deaths on the operating table, or very soon after the operation, accounted for around only half the fatal cases. And it was, as one surgeon described, the great danger that looms in the distance, that is, the expected onslaught of peritoneal inflammation, what we would call peritonitis, that was to be feared as much as the operation itself, and which was not easily factored into statistics. Different situations, outcomes, and sick bodies made it hard to imagine a definitive ovariotomy. And without a sense of what was typical, it was hard to say what operations should be included in the statistics and what shouldn't be. And you'll have to forgive this terribly ahistorical, poorly designed chart, but it helps me think about the various outcomes there could be from ovariotomy. And we've been talking a lot about death as an outcome, but the question of when that happened was quite a big issue in terms of responsibility and blame. We think of an operation as intrinsically connected to the operator. The two are indivisible. The individual operation a product of an individual surgeon's actions. And yet, as Thomas Schlick has shown in his study of 20th century surgery, surgeons have often been troubled by how statistics blur the boundaries between the two, especially when outcomes are poor. Is a fatal outcome caused by the type of operation employed, or is it by an operator's technique? If it is the former, did it exonerate an operator from responsibility? Okay. There were other problems around whether ovariotomy statistics could be compared to other major operations. So this is just one other problem around statistics or question that was emerging at this time. For proponents of the operation, making a comparison with other major operations was really important to their cause. If ovariotomy's mortality could be shown to be similar to that of other major operations, then this would strengthen their case. Opposition to the operation, Charles Clay argued, stemmed from an illiberal and conservative streak in the medical profession, happy to cut off legs at the thigh and tie major arteries because these were established practices, but unable to countenance the new, i.e. ovariotomy. In 1846, Samuel Solly, who was a surgeon at St Thomas's Hospital, and he was himself an advocate of the ovariotomy operation, collated statistics that put the mortality rate for ovariotomy at 4 in 10. He compared this to statistics for amputation of the thigh, which was 3.5, the death rate was 3.5 out of 10, amputation of the arm, 4 out of 10, and Sir Astley Cooper's hernia operations, where nearly 5 in every 10 patients had died. So he actually showed broadly similar outcomes for all these operations. But opponents cast doubt on the validity of comparing ovariotomy with these operations. For them, ovariotomy remained positioned as a procedure of choice. It couldn't be compared to an emergency operation like aneurysm, which were viewed as an indispensable emergency treatment. Ovariotomy was inherently different, one critic wrote, because it was against surgical instinct, which is quite an interesting phrase. Opening the belly was such a different thing from these other classic established surgical operations that it rendered them incomparable. This was the view of the opponents anyway. From the perspective of both sides then, statistics alone, while useful, were limited in what they could convey. And we've been talking about this throughout the day and what other forms of evidence there may have been. And so case reports describing operations in detail were seen as vital in providing colour and context to the conditions of an operation. Ovariotomy was not just a scientific question, but of course a moral one as well. Case reports were really important in conveying subjective emotional experiences more than statistics obviously ever could. And they were often published to elicit similar responses. The negotiation of responsibility between surgeons and patients was at the crux of these accounts. So it was great hearing Stephanie's talk, because I would suggest as well that the role of patient demand in enabling ovariotomy was crucial to their accounts and crucial to surgeons trying to justify the operation. It can be hard to imagine, perhaps, from a contemporary point of view, public demand for such an operation as ovariotomy in the pre-anaesthetic era. Obviously requiring the patient's belly to be cut open. Surgery at this time could of course be bloody, brutal, fearful, unimaginably painful, but living with ovarian disease could also be an unbearable burden. And there was major demand for this operation, and this factored heavily in the way surgeons represented their experiences of it. Ovariotomists stressed that if patients were above age and had been furnished with the facts by their doctors, they were more than competent in making the final decision about their treatment, and that their subjective understanding of their own lived body potentially even outweighed the surgeon's own personal feelings on the matter. Reports emphasised not only the bodily pain that might compel women to seek treatment for this condition, seek such risky treatment for this condition, but they also talked about the greater impact of the disease upon their self-image and their emotional experiences. And one particular issue with ovariotomy was that it could be mistaken for pregnancy, and this had a huge impact if you were an unmarried woman and you're being mistaken for pregnancy. Obviously, this could have a devastating impact on your life. So a lot of the surgeons talk about this as a motivation for young unmarried women, especially seeking out treatment. The narrative of Charles Clay and others described women who are determined to have the operation performed on them. These patient voices do, of course, have to be treated with some caution. They were being mediated by doctors determined to justify the procedures that they had performed. And the narratives were undoubtedly shaped by that, so we have to take them with a pinch of salt. But they tell us something, I think, about the role of the patients, the active role of the patients, and that role that has long been present in the negotiation of surgical innovation. This was particularly exemplified by Clay's first case, who survived, a middle-aged woman called Mrs. Wheeler, in 1842. And in the case, he discusses what brought her to him. And he says, "My patient began to express herself earnestly desirous of an operation, respecting which I neither persuaded her nor dissuaded her from, but faithfully detailed to her the magnitude of the means of which she sought, pointed out the particulars in every case on record with results, and rather, if anything, depreciated than added to the chance of recovery. Still, she was determined to operate." And again, he has another quote here from another patient as well, saying something similar. Equally, however, it was not unusual for patients to be blamed when the operation failed. So I think this is the other side of patient agency, is that it gave surgeons more scope to pin some of the blame on the patient if something went wrong. And I'll just talk a bit more about that. So, for example, in his third published case, Charles Clay made such an assertion in the case of 47-year-old Mrs. Dillon, so that quote just at the bottom right there. On opening Mrs. Dillon's abdomen, Clay and his colleagues have found a malignant tumour with significant vascularisation. Deemed inoperable, the abdomen having closed without any active treatment. On the morning of the 5th day of her recovery, Mrs. Dillon's family requested she be given a mixture of gin and garlic, which she was accustomed to take for her indigestion, a request that Clay denied. When later that day he visited the patient, she became seriously ill, and Clay found it impossible to reflect on the progress of the case without suspecting some interference of the most unwarrantable description in the nursing, particularly when coupled with a wish to exhibit stimulants in the morning of that day. And Mrs. Dillon died 6 days later after the operation, and Clay very clearly placed the blame with the family members who had been attending the patient and he suspected had given this mixture. Such accounts encourage readers to think deeply about divisions of responsibility in surgery. Where did the fault lie when an operation went wrong? Was it always the surgeon's responsibility? Or could blame lie with the patient or even those who attended them? And I think the aftercare period is quite an important aspect of this and who was controlling the aftercare period. Surgical operations are often assumed to be discrete events in which the role of different actors seems perhaps self-evident at first. But Clay's reports instead pointed to the malleable nature of responsibility and blame in operating, and the blurred boundaries between the operation itself and events that occurred before and after it that might influence its outcome. The ovariotomy debate became a less visible presence in the medical press for several years after Lee's confrontation with Baird. Fewer cases were published, although there are a few that crop up now and again. Charles Clay seems to be the only ovariotomist in Britain who is sort of continuing to practice on a regular basis. A new group of London practitioners, though, began to take up the operation in the late 1850s, most notably obstetric physician William Tyler Smith, Isaac Baker Brown, and the surgeon Thomas Spencer Wells, who Ulrich mentioned earlier. Isaac Baker Brown is quite an interesting case. He had a long-standing interest in diseases of the ovary, has spent many years cautioning against the operation, continuing to use only palliative and medical therapeutics to treat dropsical ovaries. By the 1850s, however, he had had a change of heart. Now convinced that these means could not affect a permanent cure, he began to advocate the operation and he started performing it in the 1850s. So I think he's quite symbolic of this turnaround you see towards the end of the 1850s. There's a noticeable change of heart, I think, in the profession in the late 1850s and then early 1860s. Many, like Brown, were not necessarily entirely confident in the operation, but by now sufficiently unconfident in the power of medical therapeutics to do anything to treat the condition. When in 1862, Lee once more publicly decried the lack of truthful representation of ovariotomy, his remarks were met much more coolly by the profession. And in 1865, we see a major turning point with Spencer Wells's publication of his monograph Diseases of the Ovaries, from which the images from earlier were taken from, which, despite the title, was in fact Wells's record of all his cases. In it, Wells provided verbose, richly informative accounts of every single ovarian operation that he had performed by then. Successes and failures, and then carefully dividing the operations into completed and uncompleted, and providing very detailed information about the patient's state of health months and sometimes years after the operation. He claimed a success rate of 76 recoveries from 114 operations performed overall. Results which 2 years later would be improved on even further by Thomas Keith, who in 1867 announced that 4/5 of his ovariotomy patients had survived the operation. But the Wells book, I think, is very important. Not only did he seed the idea that he was responsible for reviving ovariotomy, which is a slightly different question of priority, but what's interesting in terms of statistics is that the success, the positive reception he got was less about an actual big decrease in the mortality rate. 1/3 of his patients were still dying approximately, so there hadn't been a huge drop in the number of people dying. What made his book have such an impact, what people liked about it, was the way he represented his cases, the way he included statistical information as well as highly detailed case reports as well. This was what the success of the book depended on, I think. It was the way he was able to challenge this idea that cases were going unreported. It made ovariotomy respectable, essentially. But it was more to do with representation than the raw data, mortality data, I would suggest. So, just to conclude with a few thoughts. I think ovariotomy raises some very interesting questions, obviously, about evidence-making in surgery. In the 1840s, statistics were increasingly utilised by medical men, as we've seen, to make sense of new and potentially hazardous innovations. They provided control, order, they helped to answer questions about how risky an operation was. The controversy surrounding people like Frederick Bird tell us something about the impetus there was to get doctors to contribute to this collective endeavour of providing full statistics. At the same time, the weakness of statistics as a form of representation was also revealed. Establishing the justifiability of the operation proved complicated in the face of the acknowledged messiness of individual cases. Inexperienced operators, patients' bodies afflicted with pre-existing illnesses, incompetent family members interfering with the aftercare process. These all need to be taken into consideration. Thus, frank and full qualitative reports were also seen as having an important role as well. And within the history of medicine, I think there's often been this idea of doctors, and perhaps especially surgeons in the 19th century, as being very dispassionate. So for me, one of the interesting things about ovariotomy is how open the surgeons were about their fears and anxieties of performing the operation, that role that kind of, the emotive narratives play. And reflecting on the contemporary landscape of medicine, it's put me in mind, I think, of the current move. I don't know what the situation is in America and Canada, but in British there's been a lot of discussion recently about the visibility of qualitative research in medical journals. So a few months ago, an open letter was penned to the British Medical Journal, spearheaded by Trish Greenhow, who is a professor of primary healthcare at the University of Oxford, asking the journal to reconsider its role in publishing qualitative research. As you can see, this was begun by a letter to the McGill Qualitative Health Research Group, where they were told their qualitative research in general was a low priority, hence the rejection of the paper. And this is very interesting. I think as Greenhow emphasises the importance of qualitative work in showing how patients experience care and how practitioners think. So while 19th century practitioners were obviously working in a very different context, the idea of patient consent is a very different one from what we have today. There are perhaps things we can learn and think about looking back on 19th century journals and the important role that qualitative data had in the 19th century. The role of the medical journal was hugely important in this, and perhaps journals can play an active role in questioning the cultural norms which govern the ways they publish, and which currently sees case reports and other qualitative methods somewhat sidelined in favour of quantitative data. So there's some interesting things I think we can learn about how quantitative and qualitative research came together in the 19th century in surgery. So I will leave it there. Thank you.
Thank you very much. I'm interested in the introduction of new technologies or new knowledge into surgical practice, and I may have missed some of the sessions today, but I didn't hear about blood transfusion, and as far as I know, the first use of blood transfusion was in abdominal surgery, maybe even this kind of surgery in this period by Blundell, but this followed 2 centuries before experiments after Descartes and after Henry, and it was in a completely different context. It had to do with psychosis and changing personalities. So it took a very long time for this to be introduced, but were none of these mortalities related to bleeding? Was blood loss an issue? And what finally drove people to use blood transfusion? It must have been a very pressing problem.
Yeah, I mean, certainly hemorrhage was absolutely one of the complications that could occur. And you're right that James Blundell himself was an obstetrician, and I think it was that motivated him. Blundell was also quite important because he did some of the first experimental research in abdominal surgery. He removed uterus and spleen and ovaries from rabbits as a way of seeing if the peritoneum could handle interference. So there's quite an interesting crossover there. But I'm not too sure, what role transfusion itself plays in the ovariotomy story. I haven't seen a great deal of references to it, but there is certainly concerns about hemorrhaging and the best way to stabilise hemorrhage. Yeah, certainly. But I would say peritonitis perhaps governs the imagination more as the dread disease of what may happen afterwards.
I'm always struck by I just remember in my training seeing post-operative reports when surgeons used to do them by hand, and they were asked to quantify blood loss. And I remember seeing one that had a big 0, but the entire thing was blood marked. Very striking. Are there any other questions for this excellent paper? Yes.
Hi, Sally. I really enjoyed that. Thank you. I was just wondering, have you ever come across any patient accounts?
Not many.
No.
No, sadly not. These ones mediated by doctors are often the best it gets, unfortunately, and I'm always asked if I find any, but very little. I mean, there's some interesting cases. There's a few cases where ovariotomists are sued for medical negligence at the end of the century, and that those accounts are not mediated through doctors. They're mediated through the lay press. So you get a bit more sense about what the patient experience is then, but. In terms of raw archival data, really very little, unfortunately.
Great, thanks. Thank you.
I can just confirm what you said about the importance of the representation of Spencer Wells' statistics. He was very influential on the continent. He introduced actually the operation in Switzerland. He came and operated with Billroth in Zurich. Billroth spent some time in Zurich. And Billroth then took up his way of reporting every case he had operated in 2 books, which you may know, one from Zurich and later then from Vienna. And interestingly enough, Theodor Kocher, the later famous surgeon, assisted this operation in Zurich. And he too took this way of representing every case of ovariotomy. And he asked Spencer Wells, you didn't say that, but he was unsuccessful. His first paper was on 5 ovariotomies. And the 3 first were deadly, ended deadly with death.
Yeah.
And he published this. I mean, this was quite courageous for a young man.
Indeed, yeah.
But as you said, I mean, it became quite an obligation to do that. He felt that very strongly.
I think Canada has one more citizen. Is that right? Congratulations. I'm interested in the very aggressive interactiveness of the reviewers, the journal reviewers, because we've had some scandalous examples in the highest impact journals, so-called impact biomedical journals in the past couple of years of irreproducible data. And so I don't know if it was quite as structured then, 2 or 3 anonymous reviewers, but we probably would do well to get back to this level of aggressiveness. And what was the state of affairs in terms?
Well, I mean, there was no formal peer review, obviously, as we would have now, but it's very important to look at the role of the journals. I mean, Thomas Wackley at the Lancet, for example, while initially quite interested in the operation, absolutely turned against it, and this had a huge impact on the operation. He particularly wielded a great deal of power, but so too did James Johnson, who was the editor of the review as well. So it mattered what these editors thought, it mattered on the representation of the operation, and it mattered about what they published or what they selected to publish. So I think we do have to acknowledge the role that they played in this debate. Yeah.
I just find it interesting that they try to collate all the surgeries on the ovary when the ovary is such a diverse structure in itself. And it has so many possibilities of pathology, and they don't correlate with each other. And some of them are so simple to do, and some of them are so complex to do. So, and to collate and say, well, just because the title of this structure is ovary, we can put it all together. And just a point for Jerry, for Dr. Batist, the point about the ovary is that you probably can lasso the ligament very fast and control the bleeding, as opposed to the uterus and everything, or the spleen, where you can't play around like that. So I think peritonitis was a major, major player, or seeding of cancer and everything else that goes with it.
Yeah, I mean, I was just talking to Chris about that, and certainly the uterus wasn't touched because of the absolute fear of hemorrhaging, because it was so vascular. So, I mean, the understandings of ovarian pathology are obviously quite different then. It wasn't quite as refined, but towards the end of the 19th century, they do start paying a lot more attention to the histology of the tumours and classifying a bit more that way, but not as much in the mid-century.
Early on, you talked about the value of diagnosing, making the distinction between pregnancy and those huge ovarian tumors that you showed in that image. Was that considered a hard thing to do? Because it seems like the distinctions, from the, as I say, not even modern physician, but just people don't usually would confuse these two things. I mean, you wouldn't see anyone with an ovarian tumor so hard, but was there a real science that these people were talking about for how to make the distinction between a pregnancy and a huge tumor?
Not really. I mean, particularly in the 18th century. So the Ephraim McDowell example is an interesting one, because he was called because they thought she was about to give birth. So obviously the signs of pregnancy weren't understood in the way they are now, and the women themselves often thought that they were pregnant. So it did happen a lot, and hence the reason why they grow to such an enormous size as well, because people sometimes interpreted it as they're growing a child, not a tumour. So there is a really interesting kind of intersection there happening, but also as well with the social consequences of that, of, if you are married and this happens to you. And there's lots of quite sad examples of, women who are in horrendous states because they've been accused of carrying a illegitimate child. So.
I had a question about the series that people kept. Is that on? Yeah. Did you ever see the case, and I thought maybe some examples came up with Ulrich, where people began a series with one sort of technique, and then they made some change, and so they begin a new series, and then a new... I love that as an early model of this notion of the progressiveness of medicine as kind of a consolation for your earlier failures. Well, at least it's always sort of improving, and I wondered if you saw that within ovariotomy in the way that they kept records. You could have it stop at a certain point when it was clear that they'd done something new.
Do you mean in the actual nature of how they kept the record, or
in the performance of in the procedure, or in the way that they
Well, certainly, they're always. I mean, this is the problem of how you define an operation when you're constantly changing your technique in the way you perform, and therefore, perhaps renders even your own work incomparable with one another sometimes. So I mean that is certainly happening. But you do get, they do often have, it's quite interesting, you can see Charles Clay's standardised records in his archive, where he has a very precise, standardised way of recording every operation, but I'm not sure it really does justice to the variety of ways he operates.
Any other questions? Yes?
At what point does the does this procedure, I'm having trouble pronouncing it at this hour, become disengaged from the actual organ? At what point does it become a focus for all kinds of other female problems?
Yeah, it's a really good question. I mean, some people will see this kind of critical point in the 1880s, and the reason is because the ovary starts to be removed for conditions that are not to do with the ovarian pathology. So I put that as that kind of moment when you see that transition, and the idea is that the ovary essentially becomes the root of all evil, where it will cure your spinal condition, it will cure your epilepsy. Epilepsy features a lot in it. So that moment happens around the mid-1880s. More so in America initially than England, actually. So you start seeing real deviations in national practice at that time. It's happening all over, mainly kind of the medical cities in the East Coast, actually. So there's Robert Batty, who's quite notorious for removing ovaries for all sorts of perhaps quite trivial reasons. But they're very concerned. The people like Spencer Wells are very concerned that this operation is labelled. They want it to be labelled a completely different operation. They don't see it as a form of ovariotomy. They want it to be perceived as an entirely new category of operation. So you see another deviation, another divergence happening at that point as well.
Anything further? Okay, well, in that case, thank you very much,